My name is Greg Mays. I'm a member of the Norton Healthcare Board of Trustees, and I also have the honor to chair the Medical Ethics Council, which is the proud provider of tonight's program. As you can probably imagine, the setting and format for this symposium has been put through several last-minute revisions and changes. While we had hoped to have both an in-person and virtual option, unfortunately, COVID once again proved to be more stubborn than we had hoped or anticipated. So a few weeks ago, we transitioned to a virtual only option. And then, of course, today we were blessed with sleet, ice, and snow. So yesterday and earlier today, we were fortunately able to get our speakers into our studio to have their presentations recorded. It'll be the same context, just pre-recorded. You'll see that their question and answer sessions address questions that we have anticipated that you might ask this evening. But also at the end of each session, there is an email address that you can send your questions. That email address is ethicsquestions@nortonhealthcare.org. This evening's very robust programs have been developed by a planning committee under the direction of the Medical Ethics Council. The Board of Trustees created the council to, one, be a resource to the ethics committees in our various settings. Two, to develop to the development of policies and practices related to bioethics. Three, to advance organizational advances, decision-making processes, and practice in bioethics. Four, to monitor the organization's adherence to its mission statement. And lastly, but not least, to ensure the organization provides services in a manner consistent with our faith heritage. On behalf of the Board of Trustees, I would like to take this opportunity to thank our Medical Ethics Council members, everyone serving in the 6 ethics committees in the organization, the planning committee for developing the symposium, and most certainly to all of the clinicians and ethics and employees working so tirelessly to ensure the respect and care for every patient. Just to state the obvious, these last 2 years have been very difficult and very challenging for all of us. We would like to thank you for making a positive difference. Of course, Norton always tries to honor its faith heritage and traditions. And with that in mind, I would like to invite Reverend Dr. Ron Oliver, our System Vice President for Mission and Outreach, an executive liaison to the Medical Ethics Council, to lead us with our invocation.
Thank you, Greg. And if you would, join me in a moment of prayer. I pause to give thanks, oh God, for this community that's gathered together. And strange as it is, we do enjoy the connection of this moment. Thank you for the people who have worked to make this possible. Certainly hope for the safety of folks who are on the roads tonight, the folks who are seeking to keep the roads clean and clear so that travel might be necessary. And of course, as hospitals, there are people who need to come to us, and we hope that they are safe. And for those folks who are working in jobs that keep them there long past when they would normally go home because of the weather, may they find rest during the days ahead. I thank you for this cause that we are gathered around, the ethical considerations that guide our work. And I hope that this hour is of productive as we all seek to do a better job of caring for the people who are part of this creation. Thank you for all of this. Amen. Thank you again for joining us and joining together. I'm just so enjoyed, and I look forward to the time when we can be together. but nonetheless glad that we could be together this way. I'm going to give you a quick run through of our of the layout of the evening, and you'll have it. So Julie McDonald is an attorney with Norton Healthcare. She's going to talk about unbefriended patients. So you think about patients who come to us as they come through the door, maybe they don't have anybody. And then Dr. Robert Frierson is going to talk about the difference between competency and capacity. And pay attention, because his what he has to say is so very dense and specific, and it was very helpful as he recorded. It was helpful to me as he recorded this morning. Then Dr. David Hasselbacher, who is a pulmonologist, works at Norton Brownsboro, has certainly been on the front lines with COVID, is going to talk to us about non-beneficial treatment. And then I'll finish up by talking about the integrated ethics program that we have at Norton Healthcare and how that can be of help to you. Certainly, there are a lot of moving parts in this evening, and any one of these topics could be the subject for a much longer discussion, days, if not a couple of day symposium. So realize that this is just a bit of the taste, but it's going to be a very practical takeaway that you'll have. So I've characterized this a little bit like ethics speed dating. So sit in, strap in, get something warm to drink, and enjoy and the takeaways that are soon to be yours. So thank you very much, Eric. If you'll take it from here, and we look forward to wrapping up this conversation when our speakers are done. Thank you.
Hi, I'm Julie McDonald. I'm going to speak with you tonight about unbefriended patients. First, let me tell you a little bit about myself. I received my law degree from the University of Louisville Brandeis School of Law. I spent about 13 plus years in private practice representing hospitals and physicians and other healthcare providers. I joined Norton Healthcare about 7 years ago. My primary job is to oversee claims and lawsuits against the hospitals and our employed providers. I also work with the risk management team when events occur or when questions come up. I also serve on the Norton Healthcare Ethics Council, and I have no conflicts to disclose. So what is an unbefriended patient? An unbefriended patient is a patient who lacks decisional capacity to give informed consent for treatment, has not executed an advance directive, and has no known surrogate decision maker or next of kin. They're also oftentimes called unrepresented patients. Usually these patients are folks who are either homeless or they suffer from mental illness. Many of them have cut ties with their family members. Sometimes they're elderly, and they may be incarcerated. Usually see one or two or more of these factors when we have an unbefriended patient in the hospital these days. So why are unbefriended patients significant? They're significant because they do not have an authorized decision maker available to make difficult decisions about their medical care. Sometimes this results in them receiving non-beneficial treatment that can increase their pain and suffering because no one is available to make end-of-life decisions, to say, stop, please make this patient a DNR. Unfortunately, we continue to provide care even when we know it's probably going to not be beneficial for the patient. So how common are unbefriended patients? The exact numbers are unknown. We estimate there are probably over 100,000 in the United States. A 2006 study actually found that 16% of patients in an urban ICU were unbefriended. We guess that's probably more now because the increased substance abuse disorders and increased homelessness that we see in the United States. But it's really an impossible number to know. So who makes decisions when we have an unbefriended patient in the hospital? Some may say, well, what about the hospital's ethics committee? And that's a position that's advanced by the American Medical Association. Some may say, what about the patient's treatment team? They're the ones who are providing care and know what's best for the patient. And that's a position that's advanced by the American Geriatric Society. Others may say, why not a court-appointed guardian? And that's a position that's advanced by the American College of Physicians. And the actual answer is, it depends on the state law in which the hospital is located. 12 states or so have actually specific laws in place, but they vary between one another as to what they suggest. Some states, like North Carolina and Nebraska, allow the attending physician to make decisions for an unbefriended patient who may need life-sustaining treatment. Other states, like Arkansas and Tennessee, require that the patient's attending physician consult with a second independent physician to make those decisions. And other states still, like Colorado and Montana, require a medical ethics committee to make those decisions. The other 38-ish states are completely silent on what to do with unbefriended patients. So what about Kentucky? We, of course, are silent on the issue. We don't have a specific law in place to deal with these types of patients. Under Kentucky law, there's a hierarchy of who can make decisions when the patient doesn't have capacity. First is a court-appointed guardian, if there is one. Next is a healthcare surrogate or medical power of attorney, if the patient has given us that information. Then it would go to the spouse, the patient's children, the patient's parents, or other nearest living relatives to make decision. The problem we have is that Kentucky doesn't allow us to have anyone else make a decision. It has to be a relative. And so sometimes these unbefriended patients literally have no family. So unless it's an emergency, meaning it's an immediate threat to the patient's life, we're sort of stuck. So what we have to do now is we have to go to court and get a court-appointed guardian to make decisions for the unbefriended patient. So what is guardianship exactly? Under Kentucky law, a guardianship may be necessary when a person is disabled, meaning that he or she is at least 17 years old, but is unable to make informed decisions with respect to his or her personal affairs to such an extent that they lack the capacity to provide for their own physical health and safety. These may be medical decisions, it may be things like food, shelter, or personal hygiene. Or it may be that the patient is unable to make informed decisions with respect to their financial resources. So when that happens, the law outlines the process for how a guardian would be appointed. The patient has to be examined by an interdisciplinary team. That includes a physician, a social worker, and a psychologist. And then within 60 days, the court holds a jury trial, so actually a jury, 6 or more adults who are going to make this decision, and they're going to decide whether or not the patient is disabled and determine the scope of the guardianship or a conservatorship, meaning they may be disabled as to their medical decisions, but they still can make other decisions for themselves. They may be disabled as to financial decisions, but they may still retain the right to make medical decisions. It just depends on what evidence is put before the court. In certain situations, the court will entertain what's called an emergency guardianship, and that could be held within 2 to 7 days. But the only time that a court is going to have an emergency guardianship hearing is if the patient is in imminent danger to their health or safety, and then you have to have a notarized letter from their physician. The problem we find most frequently is that the unbefriended patient isn't in imminent danger. They may have a slow and chronic disease process that's ongoing and is going to lead to their death at some point, but they're not in imminent danger, so we can't get an emergency guardianship. We have to go the traditional route, and obviously that may take 60 days or more. So the disadvantages of having a guardian appointed is that the process is very slow, it's inefficient. Sometimes you have people coming in to evaluate the patient who don't really know much about them. And then when the guardian is appointed, it's oftentimes somebody who doesn't know the patient and they don't know their preferences, whether or not they would want life-sustaining treatment or not. So let's talk now about the ethical dilemmas in caring for unbefriended patients. First, this is a highly vulnerable population. These are patients who are unable to advocate for themselves. They don't have any family or friends who can advocate on their behalf, and they're very dependent on medical providers to make decisions and to guide them in a direction to provide their care. It's also difficult to demonstrate respect for these patients because the clinician is oftentimes unable to learn about the individual's values, their goals, or their preferences. And sometimes that means if the patient's wishes aren't known, we can't follow them. The patient may also not receive appropriate treatment because we don't know what the goals of care are. So sometimes we overtreat them, sometimes we undertreat them, and sometimes they're subjected to delayed treatment, meaning we wait for an emergency to happen before a decision is made. These patients may be discriminated against because their treatment decisions can be influenced by medically irrelevant characteristics, their homelessness, their alcoholism, their drug abuse, things like that. These patients are often members of marginalized groups, so that can result in discrimination, even if it's unwitting. Finally, there's an undue influence in decision-making with these patients. Sometimes financial interests may be at play. Sometimes it's, we need ICU beds because there's a big COVID surge. What are we going to do with this patient who's unbefriended and it clearly is going to die in the near future? So what do we recommend to do for unbefriended patients? First, the big part that I see is that we need to do more to promote advanced care planning. We need to do more to utilize advanced directives, powers of attorney, most forms. We have tools available. We just need to get them in our patients' hands to let them specify what kind of care they may want in the future, or to designate a healthcare surrogate and tell us who are the people that you would want to make decisions for you, assuming you're unable to do so for yourself. We also need to implement strategies to identify decision makers. Sometimes it's, the patient comes in and we have a bad contact information and that's all there is. Well, we need to constantly reassess the patient's decisional capacity. Sometimes that can change. Sometimes in the morning, the patient may be lucid and coherent and can talk with us about their goals of treatment, but by the evening, they're not. So that's something that can change throughout the patient's hospitalization. We also need to be diligent in our searches for finding a suitable decision maker. We need to make sure we're trying to get that information on admission when they're readmitted from the nursing home or wherever else other sources we have to identify who may be best to help make decisions. And finally, if there's anybody who has shown concern for this patient, maybe a friend or someone else, we need to have them involved. And sometimes it may be, what can you tell us? What do you know about the patient? What do you know about their family background? Okay, you said they have a son. What do you know about him? So that we can try to really chase down those leads. Next, we need to make sure we're engaging in collaborative decision making. Our clinicians need to quickly reach out and enlist assistance from other professionals. We need to get our care managers and our social workers involved to make sure that we're doing all of the things that we can do to help try to identify who is an unbefriended patient and is there somebody else who can speak for them. We need to use all available resources that we have to talk about what would the patient prefer. The patient may not be able to tell us in their current state, but we may know what is their religion, what is their culture, what are those preferences and their background information. What would that tell us probably is the right decision for this patient? And then finally, we need to assess the risks and benefits of what we're doing for the patient. Are these essential procedures? Are they going to affect the treatment plan? Do the risks outweigh the benefits? Or are we just doing that because we think it's the next thing to do? One of the leading medical ethicists and law professors on this issue is a gentleman by the name of Thaddeus Pope, and he published an article in 2020 which sort of proposes a new tiered approach for how we should handle these unbefriended patients. And what he suggests is, if it's a low risk or routine procedure, something that's an accepted medical practice, then perhaps the physician should be the one to decide. If it's major medical treatment that would normally require written consent, like a surgery of some type, then maybe the requirement should be that a physician is going to consult with another provider or an ethics committee to make sure that everyone's on the same page. But then when it comes to life-sustaining or high-risk treatment, that's a time that a physician needs to get approval from a larger group to make sure that we're doing the best we can for our unbefriended patient. So if you want to read an interesting article, go out and Google Thaddeus Pope. He's got an excellent website, lots of resources, and you can find tons of information about unbefriended patients there. What have we been doing at Norton Healthcare? We've done a couple of things in the last year or two to try to reduce the number of unbefriended patients that we see. A couple of years ago, Care Management obtained a subscription service to a database that will allow them to search individuals to help identify relatives. So if you have an unbefriended patient, you can call Care Management and say, here's the information we have on the patient, here's their name, date of birth, social security number, and they can put that information into the subscription service, and we can sometimes get some identification that way. We might identify some relatives, we might, find other information, and so we've had some luck with using that service over the last year or two. We also engaged in a pilot project at Norton Audubon Hospital last year, where each day the chaplains were provided with a list of patients who had no next of kin identified on their admission papers. Meaning if they had said, my emergency contact is my neighbor or my friend, if it was not a relative, we were flagging those patients to say, can you give us someone else who might be able to make these decisions for you if you're not able to do so? We've had some luck with that. It's not been great. Sometimes we find these are patients in the ED, and by the time we get to them, they're already gone. Or sometimes these are patients who are in the ICU, and by the time the chaplain gets to them, they're not in a position to talk to us. But we have had some luck in explaining to these patients, look, we're happy to call your neighbor if there's an emergency, but if we need somebody to make medical decisions for you, your neighbor's not going to be able to do that unless you've specified in a POA or some other document that says, this is the person I want to make decisions for me. And then hopefully in 2022, this is still in the works, we are working with Epic, our medical records company, to use a tool called Advanced Care Planning, which is something that already exists. We just need to pull it into the Norton system. And this is something that would be used in both the hospital and ambulatory worlds that we can do with patients, where they can even upload documents that can tell us this is my POA or these are my end-of-life choices. So hopefully that's going to happen this year, and that will help us get to know our unbefriended patients a little bit better. What about on a statewide level? Well, in 2019, the Kentucky Medical Association issued a resolution and requested that the state legislature amend the law to allow 2 attending physicians or a hospital ethics committee to make the decision to withdraw treatment for an unbefriended patient. It was a resolution, and as far as I can tell, there's never been any action by the legislature on this topic. Personally, what I would like to see is that we would lobby the legislature to amend the statute, KRS 311-631, to allow a close friend to make decisions for an otherwise unbefriended patient. So if we go down the hierarchy of who makes decisions, the last entry on there would be the close friend. Other states like Indiana allow this. And so sometimes if we can establish, yes, this is a close friend, they know a lot about the patient, they know about their preferences, then that person is the one who can make decisions for the patient. Some additional resources, I highly recommend the July 2019 American Medical Association Journal of Ethics. It has several articles that touch on many of these issues we've discussed today. There's also an excellent publication from 2020 from the American Journal of Respiratory and Critical Care Medicine, where they talk about their policy statement and how we need to incorporate some of the things we've talked about tonight. And then I've also included the website for Thaddeus Pope, who I mentioned earlier is a law professor and bioethicist who is very involved in this topic. So thank you all very much for your time and attention. We'll take questions.
Well, thank you, Julie. As you know, you're on my my list of quick dials because these questions come up with such frequency. Thank you for introducing that topic to us. You mentioned living wills, and these things have been around a long time. They don't seem to be very well utilized or very widely utilized. But when you say living will, what does that do for a person? Why would that be important for a person to have one of those things?
Sure. So a living will or an advance directive, these are documents that the patient can complete where they say, yes, I do want to be coded, or no, I don't want to be coded if I'm ever in that situation. They can say, I do want things like artificial nutrition and hydration, or I don't want artificial nutrition and hydration. They can specify when I get to that point in my life and it's a very critical situation, I want you to do everything, I want you to do nothing, I want you to allow me to die naturally. This allows patients to tell us, this is what I want, and then what we do is we can scan that into their medical record, and then that way when they show up at the hospital years down the road, we have that information and we can go look it up and say, look, this is what the patient told us they wanted, and that really should be the decision that's made.
And I'm guessing that advance directives usually also have a healthcare surrogate sort of boxed in with that.
Sometimes, not always.
Not always.
So healthcare surrogate means I can specify I want this person, Mr. Jones, Mrs. Smith, to be the one who's going to make decisions for me. And you can even specify I want these 2 people, or if this person's not available, I want that person to be the backup decision maker. But it tells us, if I can't make decisions for myself, this is someone that I trust, and this is who I want to make decisions for me.
I know it's been more frequent than I care to remember that somebody around the bedside will say, well, I'm the POA. I'm the POA. And they announce that with great vigor. And it is as if, they've got the ace of spades and can do whatever they want. And absolutely most of them are certainly very, very well intended.
Sure.
I'm guessing, though, that maybe you would like for the providers to ask some questions of that person who says, hey, I'm the POA, do what I say.
Yeah, we've had that come up. It comes up a couple of times a year, every year. And what we really need is we need the document. We need the actual paper that says, Ron Oliver is my POA. Because sometimes you can have a POA, but it can be for something like selling your house. Or it can be for all kinds of things except making medical decisions. So when we say someone has a POA, we need to make sure that healthcare decision-making falls within the scope of that power of attorney. So we have to have the document to make sure that, yes, you are that person, but this is something that the patient wants you to do for them, and that is to make medical decisions.
Read the document.
Read the document, yes.
You mentioned most. You said most and I think that's relatively new in
Sure.
in the Commonwealth. This is really not so much about that, but you mentioned it, and I thought, well, it'd be good to know what that is.
Sure. So MOST stands for Medical Orders for Scope of Treatment. And this is something that was introduced in Kentucky in 2015. And I will say 40 plus states have something like this and had something like this long before we did. They may use other terms such as POST, POLST, WOLST. But essentially what it is in Kentucky, it's going to be a bright pink piece of paper that the physician and the patient fill out together, and they talk about those things. Do you want to be resuscitated? Do you want artificial nutrition and hydration? Do you want things like antibiotics? When you get to this point, how are we going to take care of you? What treatment do you want or not want? And so it's sort of a check the box form. And they check the boxes, and the physician has to sign off on it, and the patient signs off on it too. And the thing about MOST is that it's portable, meaning it goes with the patient. So if the patient goes into a nursing home, the MOST goes with them. Then if the EMS brings them to the hospital, it goes with EMS, and EMS follows it. And then it goes to the hospital, and the hospital follows it. So it's a portable document. And MOST was intended, when it was passed, this law was passed, it was intended to be used on patients who have a chronic progressive illness and really kind of have a life expectancy of 1 year or less. Now, just because that's your life expectancy doesn't mean you won't outlive it, so you can change your MOST. If something changes with your health care, you can say, hey, doctor, I know we talked about last time we didn't want to do this. Now I do want that treatment. So it can be changed. And also with MOST, what's nice is, unlike advanced directives, with MOST, you can have the healthcare surrogate complete the form. So if, say, the patient has lost decisional capacity, their decision maker can sit down with the doctor and go through the MOST form to specify these are the things we want in the event something happens with the patient.
And I think it just feels obvious to me that having a MOST or an advanced directive, if a person isn't well connected, doesn't outlive their family, that's probably really helpful tools to direct their care.
Absolutely. That is the best information we are going to have about what this patient wants or does not want when they reach that critical point.
Okay, one more advanced directive question, then I'm going to move on to a different topic. So when do advanced directives expire? I mean, when do they, sometimes we get them saying, oh, this was filled out a long time ago.
Right.
We don't know if they really, really, really mean this.
Right. Advanced directives actually never expire. So if you filled one out 30 years ago and you haven't done anything with it since then, it's still good today. Now, most forms are only good for 1 year. So if it's older than a year, that's probably not something we're required to follow. Now, arguably, we would say, gosh, that still tells us what the patient wants, and assuming they haven't changed their mind, that at least tells us what their wishes are. But it's not actually in effect any longer because it's expired. Now, where it gets interesting is when you have the patient who completed an advance directive 30 years ago and then completed a MOST form 6 months ago, and they don't line up with one another. So under Kentucky law, we have to defer to the advance directive if there's any conflict. So when a patient fills out their MOST form with their provider, what we always say is you need to make sure they're consistent. And if they're not consistent, the patient needs to do something to revoke that old advance directive, because otherwise that's the one we have to follow. It's never easy.
Yeah, never easy. That's why you're on speed dial, Julie. So, common law marriage. So, people have been together a long, long time. They've had children together. Maybe they have grandchildren. Didn't decide it, for whatever reason, decided not to be married. I guess those kids could be decision makers, but I'm thinking, that
Right.
that common law spouse is.
They may know the patient better than anyone else. They may have had those conversations with the patient about what do you want or what do you not want. So Kentucky does not offer common law marriage. So if you said, gosh, we've lived in Kentucky our entire lives and we have a common law marriage, I would say it's not valid here. Now, some states do have common law marriage, and if it was valid in the state in which the marriage occurred, then Kentucky would recognize it. So if, for example, they lived in California for many years, they said we had a common law marriage in California, we just relocated to Kentucky 2 years ago, but we've always lived as common law husband and wife, then Kentucky should recognize that as the husband and wife.
Never a straight line, is it?
Never.
Never a straight line. So, last question. If you were talking to somebody as an attorney and this person was, for whatever life circumstances, was not connected, and certainly they are anticipating, needing to be hospitalized, what would you say you really need to do these things? What the 1, 2, 3 things that you'd say, look, be sure you do these things?
Absolutely. So I would say first and foremost, you need to complete a living will. You need to tell us what you do want or what you don't want, because your healthcare providers aren't going to know when you come in the hospital what, we've got to figure out what's going on with you and what your prognosis is. But we need to know when we get to that point that decisions have to be made, what decisions do you want us to make? Because you may not be able to tell us yourself. And if you can't tell us yourself, in addition to specifying what you may or may not want, I highly recommend everybody have a healthcare POA or a surrogate decision maker identified so that we know who's the person who's supposed to be making decisions for you. And, sometimes that's even a good thing to have where, maybe the patient has 2 children and we know they're not going to agree because they've never agreed on anything their entire lives. So sometimes you can say, I want this person to be my POA, and that means that's the one who's going to get to make the decisions, regardless of the fact that both are your children. If you say this one's going to be the one to make the decisions as my POA, that's who gets to make the decisions.
Julie, thank you for your help.
Thank you.
Good afternoon. My name is Dr. Robert Frierson. I'm the Director of Consultation Liaison Psychiatry for U of L and also the Director of Psychiatry for Norton's. I was formerly at U of L the Ethics Committee Chairperson, so I've had some experience in ethics. And what I do now is see patients on a medical or floor who have either psychiatric issues or previous psychiatric history. So we see a lot of patients where capacity and competency are issues. And I'm going to talk to you more about that today. So I'm glad to be here. I wish you were here live, but we'll make the best of it. So just a brief summary. Competency asks questions like, will the patient ever be able to live alone? Will the patient ever be able to make their own decisions? Will the patient ever be able to manage their own affairs? While capacity asks questions about, in this specific incident, is the patient today able to make decisions? So in general, competency deals with the future and capacity deals with the here and now. And that's a big important difference to keep in mind. So why is this an important topic? This first slide shows you a little bit about the reasons for that. It helps to avoid a lifetime label of incompetence. There's a tremendous social and emotional distress that occurs when patients are declared incompetent. And we want to try to minimize that if we can by dealing with specific situations and capacity and not labeling somebody incompetent without good reason to do so. It makes determinations for a decision that's made now in time and not predicting the future. It helps to preserve patient autonomy and patient dignity. It honors end-of-life decisions, and it creates a person-centered approach to care. And also avoids unnecessary legal costs. Once you're declared incompetent, it is almost impossible to get your competency back unless you go to court, and that can be very expensive. So we want to separate capacity and competency and show you what the difference is so you don't make the mistake about labeling somebody who's just temporarily incapacitated as incompetent for life. So here's the definition of capacity. The ability to understand significant benefits, risks, and alternatives to proposed health care, and the ability to communicate a health care decision. That's an important definition to know. Capacity is determined by caregivers, either psychiatric caregivers or medical caregivers, and by itself has no legal standing. The judge may consider your opinion in his competency evaluation, but he's not required to. And many judges will go and have a court-appointed psychiatrist to make the decision. So again, we, as a medical professional, we can make an opinion, but it's not a legal decision. Capacity can fluctuate over time. Very often we see a patient who is confused and delirious on one day, and the next day they're better. So we always reevaluate them. It's not a permanent decision. It's only based on this particular intervention with the patient's particular day. So it's not something that is future predictive. And capacity does not involve the broad removal of human rights that are associated with competency. So when you're determining capacity, these are the questions you want to ask. These are important to keep in mind. What procedure do your doctors want to perform? And when someone calls me about an evaluation for decisionality, I always ask them, what is the decision? Because it's really important to know what the doctors are proposing to know why the patient's refusing, whether or not they have the right to refuse. So what procedure do they want to perform? Why do they want to do that procedure? It's a really important question. And a lot of times the patient has been told these answers to the questions, but they don't remember them. They were overwhelmed by all the information they were given. They weren't ready to hear the answers. So the doctor may think they've told the patient everything, and the patient doesn't remember anything at all. And it's all a matter of timing at some point. So what would happen if they did not perform the procedure they proposed? That's important. The patient may be able to say that they would die if they didn't have the procedure. And then the next question they say they would die is, do you want to die, or do you want to get better? That's a really important question to ask patients, because very often suicidal patients will have the procedure done in the hopes they may not survive it. So just always keep in mind that the patient may have ulterior motives for even saying yes to a procedure. So you always ask, do you want to die or do you want to get better? If they say they want to get better, then that's a good predictor as far as capacity. What are the complications for having the procedure? Do they know what the side effects could be for having the procedure? And why are they refusing the procedure? That's important to ask them as well. We had one patient who refused to have surgery, and his reason was that he thought they would put some poison in the anesthesia, and that's the way they kill patients. So until he got to that point, he sounded pretty capable. But then when his reason for not having the procedure was psychotic, so he was not able to make that decision. So these are the questions you want to ask, and they're really important to go through all those questions. That's how we determine capacity at the bedside. So again, do you know what they want to do? Why do they want to do it? What could happen if they do it or if they don't do it? What are your reasons for saying no? And those are important questions to ask to determine whether somebody is capable of making a decision about a surgery or a procedure. So if you're the person who's trying to obtain consent, usually done by the surgeon or the medical professional, these are the things you need to take into account. Their intellectual level. Very often if patients are intellectually slow, have a history of being in special classes, you have to be very specific, very concrete, down to earth. Repetition is really important. Diagrams are helpful as well. If the patient has some kind of visual or hearing impairment, make sure that you have someone there who can help you communicate with the patient, and you don't want to assume that everybody can understand what you're saying as far as being able to hear and being able to comprehend it. Use layman's language and not medical jargon, really important with patients. If the patient does not speak English, use an interpreter present. It should not be the family. It should be an interpreter who's not associated with the patient. Be prepared to repeat what you say and use diagrams as well. That really helps the patient as well. If possible, give the patient the option to speak to someone who's had the procedure and done well. That's really important. Some role models are very important for patients. And you can tell them all day about how it will help them, but unless they see somebody who's actually had it, they won't believe that. So it's really important to have somebody, if they're available, who have had the procedure done to talk to the patient as well. And don't be in a hurry. Take time to answer questions. It's really important because the patient may have questions later, but if the patient sees you're in a hurry, they'll pretend they know the answer to the question and won't ask you, and that really is negative as far as obtaining a reasonable consent. If you can, have a family member or a witness present when you have especially a witness who can document what you've told the patient. Ask the patient to repeat to you what you've told them. That's really important because you want to say to the patient, now, I talked to you about what we want to do. Can you tell me what I told you? I talked to you about why we want to do this. Can you tell me why I told you that? So make sure the patient repeats what you've told them. That's really important to do. And that way it gives them an idea about what they've actually comprehended and understood and what they've retained. Is really important. Remind the patient that even if they say yes or no, they have the right to change their mind. Very often patients think once they make a decision, it's over. So I tell patients you have a right to say yes or no, and you have a right to change your mind. We'll follow your wishes. So if they're capable of making a decision, they may be able to change their mind, and that's okay. We've had many patients who would go down to surgery and get down there, and they'd be ready to do the surgery, and they would change their mind and come back up, and the doctor was frustrated. But when you say someone's capable, they have the right to say no and yes and to change their mind. That's important to keep in mind. You want to make sure the patient has not received just an analgesic or some kind of mind-altering medication before you talk to them. That will affect their ability to make decisions. So try to avoid someone getting a painkiller just before you talk to them or some kind of benzodiazepine or anxiolytic because that will affect their cognition. And the most important thing, the last one, be prepared to take no for an answer. That's really important. What I've seen over the years is that when we have patients who are referred for capacity evaluations, if the patient says yes to what the doctor wants them to do, they're decisional. When they say no, then they're not decisional. So we're called with patients that say no, basically. But if they are in fact decisional, they can say yes or no. When they agree with the doctor can just think, okay, they're able to make decisions, but that has nothing to do with it. It's the patient makes a decision. So they can be prepared to say no, to take no for an answer, and to go with that if that's the patient's wishes. So that's how you obtain consent. Those are the questions you ask. It's also important to do a mental status for these patients as well. When I see a patient, when psychiatry comes to see a patient, the patient automatically believes that we're here to talk them into the procedure or to say that they're crazy and they don't have a right to make the decision. So I say to the patient, I'm here to talk to you about what you're going through, what it's been like for you, who's there for you, what do your doctors want to do, and I want to know what you think about that. So the patient very often is, for the first time, given a chance to explain in their own words what they think about the procedure. And they very rarely will refuse to talk to us. They know they're from psychiatry, and they know eventually we're going to come and see them. But because nobody's ever let them just kind of free associate and talk with how they're feeling, they always talk to us when we ask them those questions. So I don't just go in and say, we're here to find out why you can have the procedure. I say to the patient, I know you've been through a lot, and it's difficult, and I know that it's hard to make these kind of decisions. I want to be here for you, and I want to give you a chance to tell me what you want to do and why you want to do it. And that sets the tone for a good conversation for the patient. So we check orientation, time, place, person, and situation. If the patient in the hospital, you lose track of time routinely, so that's not important. The days kind of run together. If they don't know who they are, that's a pretty ominous finding, and that obviously will lead you probably at some point to say they're not able to make decisions. They don't know who they are. And the situation, they know why they're here and what the reason for their hospitalization. That's an important question to ask them. We ask them about their judgment, both historical and hypothetical, their memory, especially for immediate events. And we don't ask them the memory in terms of what did a doctor tell you, because sometimes they don't want to remember that. We ask them in terms of remembering different objects, when is your birthday, those kind of historical dates to check their overall memory. Because very often the memory for what the doctor has told them about the procedure is affected by depression, paying attention, don't want to hear it, timing. So those things can affect memory. So we check memory in a more concrete sense. Thought content, are they suicidal? In general, someone who's suicidal cannot really make a decision about capacity because very often they want to die. They want to have the procedure so they don't survive it. Are they psychotic? Do they believe that someone is trying to kill them? Are they paranoid? So you ask all those kinds of questions because those can affect whether or not they are decisional. Level of intellect and whether they have concrete thinking, are they tangential? So this is the mental status exam we do for somebody where we're trying to determine capacity, and these are important questions to ask. The most important one, though, is orientation of situation and the suicidal ideation in the presence of psychosis, because those patients, they have those conditions, are not going to be able to make decisions. if the patient is extremely depressed or suicidal, it's really important to evaluate for that. But sometimes it's passive suicidal ideation. The patient will say to you, sometimes I feel like I don't care whether I wake up or not. They're not actively suicidal. I don't care whether I survive. I don't know why God lets me live. Those kind of questions. And those patients have lost their investment in living. And so these patients who have surgery and procedures they don't really want to have do very poorly afterwards. So they have no investment in recovery. So they tend to have all the major complications and all the side effects, and because they really didn't want the procedure in the first place. So unless the patient really has some investment in recovery, they're going to have poor outcomes with any kind of surgery. So some patients who are very depressed and suicidal will agree to the procedure in the hopes they will not survive it. They're suicidal, but they don't really have the courage in their mind to do it themselves, but they wouldn't mind if the procedure led to their death. I think that's, so it really don't just ask about active suicidal ideation, ask about passive thoughts about being better off dead, and it's really important to ask the patient. Very often you can miss those and assume someone has the right to say yes when they're hoping, in fact, that the procedure will have complications that they will not survive. If they're unable to give consent, this varies in different states, but in Kentucky at least, the spouse, majority of the available adult children, the parents, majority of available siblings, and physicians in emergencies, most hospitals, 2 doctors can sign for the patient if it's an emergency. So this is the hierarchy in terms of who can make the decision if the patient is unable to make that decision. So patients at risk for negative outcomes are listed on this slide here. Those whose surgery was approved by a decision maker against their will, again, have negative outcomes. Those who are severely depressed and have no investment in recovery. They have those who have psychotic features. Those who have active substance abuse disorders as well. Those who have delirium from a bad outcome of previous surgery, they're delirious or some side effects or prolonged intubation, they're more likely to have a poor outcome. Those who have problem with their physician as far as communicating with them have poor outcomes, and those who have a very poor support network. It's very important to who's there for you. It's just, do you have family? Are you religious? Who's going to be there in case you have some kind of difficulty emotionally? So those who have a poor support network tend to have a very poor outcome for any procedure, and certainly for major surgery. We're often called to ask about patients who have end-of-life decisions, and very often the patient will say, I've had enough, I don't want anything done, and the family will want everything done. And so you come and see the patient, and the patient and family are at odds, and sometimes the patient will agree to procedures only to placate the family. And I think that's really important to say to the patient, you have the right to say no, you have the right to say I've had enough, you have the right to change your mind, because very often the patient will go through all kinds of procedures that they don't want to have because they think the family wants them to do it. And the family they want that person they knew 20 years ago when they were healthy, they want that person back. And it's very often they're in different places. So sometimes talking to the family and letting them know that the patient has different opinions is really important, and giving the family a chance to debrief and talk. Because very often they want the patient to survive, but they don't think what the quality of life. We always focus in these evaluations on not so much quantity, but quality of life. It also is important to talk to the family about what the patient said when they were lucid. Did they say something when they were not disoriented? That say, if something happens, I want this done, I want that done. So we tend to focus more on those periods. Very often patients will say, if something happens to me, I don't want any more surgery, or I don't want to be on a respirator. And then they could be confused and no one knows the answer. So it's really important to record those kind of comments, because we go back to that and decide what the patient needs and wants. And the family is more likely to accept it if they know the patient has said that. So again, try to get the family and the patient on the same page. But in general, a patient who is capable and competent has the right to make decisions even against their family's wishes. And we have to tell patients that and their families as well. So that can be an issue for a social worker, or our chaplain can be helpful as far as making those decisions made, but it's really important to keep in mind that the patient is the final decision maker. Again, as I mentioned before, we tend to assume patients are capable of making decisions when they make those decisions that we agree with, but that's not always the case. And for confused patients, again, like I said, just go with the decisions they made when they were lucid. That's really important to go back to a period of time when they weren't confused. Everybody who's medically ill will eventually get confused. So it's really important to go back to the time when they were not that way and make their decision and follow their lead at that time. It's really difficult, because sometimes you get a patient who's very young, who's making a decision about wanting to die. And I think it's really hard to talk to those patients, because But it's not about how old they are, it's about what they've been through. And a lot of times they've agreed to a lot of procedures they didn't want to have, and they are really just tired. And so I tell doctors, sometimes patients to the point where even though you have something that might help you to help them, they believe that they've been through enough. And it's also important to talk to the doctor. A lot of doctors have a hard time dealing with death. They have a hard time accepting the fact that they have something to offer that patients don't want to take because they're tired of other procedures. So it's really important to talk to the doctor to say about their frustration, because they will talk to you and say, I'm really frustrated. We can help this patient. They won't let us help them. They must be not able to make decisions. And I say to the doctor, they've been through a lot. It's nothing personal. It's just that they are tired. And the general principle about competency is that everyone has the legal right to make bad decisions. And that's an important thing to keep in mind. So competency, as opposed to capacity, is more generalized than capacity. It may not be in reference to a specific procedure or a decision. It's a legal action. It's taken by a judge. And it may include things like guardianship or conservatorship as well, not just competency. It predicts the future, basically. It may take away certain rights of the patient, rights to live alone, rights to drive, rights to make decisions, and it tended to be permanent. The only way to reverse it generally is if you go to court, and that can be extremely expensive. So unlike capacity, which varies from day to day sometimes, competency, once you're declared incompetent, can last a lifetime. And it's really hard to see a patient who's older, who's lived their own life, who's been independent, who's been able to drive, who's made decisions, who has their own home, to be able to say that we're taking all that away. And I think that's why it's important to make the decision between capability and competency, because once you say somebody's incompetent, it can be a lifetime decision. Very often we see someone who we're evaluating for capability, and they may change the next day, the next hour sometimes, the next day. So we always come back and we say, we saw this patient yesterday, they were delirious, they were confused, they could not make decisions. Today they're better. Today they can make decisions. And so it's a fluid situation, whereas competency, once you do that, is pretty permanent. The other problem about competency is the patient may get a guardian. They don't want to be their guardian. They don't have a decision to make about who the guardian is going to be. That's really important to keep in mind. And also, if they can have a family, they sometimes get a state guardian who has no investment and no relationship with the patient. And that is, again, a really hard problem for the patient to have somebody as a guardian making decisions for them that they've never met and don't know. And you're hamstrung because you can't do anything with the patient unless that state guardian approves. And so again, it's a way of removing patients' rights and the patient's autonomy. And so we want to not go that way if we can avoid it. The judge follows recommendations. The judge, like I said before, can follow recommendations that the psychiatrist makes, but he is not obligated to do so. He can appoint his own psychiatrist. It's very rare they will go against us if we say the patient is not capable. They will almost always say they're incompetent at some point. So it's really important to think that when you make that capability decision, you may be influencing the judge in terms of what he's going to do. So it's really important to be on the right page when you say someone's not capable of making a decision. But in general, incompetency, once it's given to the patient, creates both emotional and social distress for the patient. And again, very often people get very depressed, sometimes suicidal because of the incompetency determination. So again, competency moves from an area of not being able to make a specific decision, not being able to make any important decisions such as living alone or making financial decisions, operating a vehicle, etc. So again, it's a permanent thing. These are some of the competency considerations. Can the patient live alone? Can they be safely discharged from the hospital? So the guardian has the right to say, don't discharge the patient. And we have patients who've been in the hospital for months while they're trying to find placement for the patient, but you cannot send them home against the guardian's will. So that also can affect the patient. And the patient is asking, why can't I go home? And it's because someone has declared them incompetent and the guardian has said to keep them in the hospital. So we can't do surgery or any kind of procedure without the guardian's permission. And again, guardians, like everyone else, there are good and bad ones, and some have never met the patient. And so sometimes the doctor is very frustrated because the guardian is making decisions that he thinks are not in the patient's best interest. And the patient is not actually chosen that guardian, it's a state guardian. So just kind of keep in mind that once you go down that road of incompetency, it's really hard to get back. We talked, can they manage their own financial affairs? Can they choose their medical or financial decision makers? Is really important as well. So when you have somebody who's lucid and you talk to them about decisions, it's very important to say, if you can't make decisions, who do you choose to be your decision maker. Even if it's not been legally established, who would you like to make your decision? And it's really important to get that documented in terms of what the patient said, because that is the person they have a relationship with that they trust. And it's better to have that person than some stranger they've never met. So I always ask the patient, if you really do decompensate, we hope you don't, but if you do, and you have to have a respirator or resuscitation, do you want that done? And if you get to the point, and again, we hope you don't, where you can't make decisions, who do you want to do that? And just document that. It's really important to do that. Again, we talked a little bit the consequences of the incompetency declaration. Again, the patient may not have chosen the person who's going to be their guardian. If there's no family member, you give the state's petition to be the guardian. And again, there's an increased risk of adverse effects because the patient has no investment in recovery. And again, I say to doctors all the time, a patient who is incompetent cannot say yes or no to a procedure. If they say yes, you can't accept that because now they have a guardian. And so it's pretty frustrating in physicians sometimes. They say the patient is finally saying yes, but now they have a guardian, so you can't take their yes as an answer. You have to go back to the guardian. So the principles to keep in mind as far as competency, everyone is considered competent unless legally declared otherwise. It's really important to keep in mind. You have that as your badge of honor, everyone does, until a judge takes it away. Everyone has a legal right to make bad decisions. Again, we all have that right. And so sometimes you can make it, patients making a decision you know is the wrong decision, but they're competent, and so you have to go with their decision. If the patient's on a 72-hour hold or mental inquest warrant in the hospital, which is holding in the hospital, that does not give you the right to treat them against their will. It only gives you the right to hold them. So it's really important to keep that in mind, that a 72-hour hold or a warrant does not allow you to treat the patient against their will. You have to go get a court order for that. It only allows you to hold them in the hospital until a judge decides they can leave the hospital. But that is not an incompetency determination. It's just a detention warrant. Before we get to the summary, we have a case report here. We have a 78-year-old female with a history of COPD, hypertension, and diabetes, admitted with shortness of breath and fever. Her past history included a number of surgical procedures, and the most recent of which resulted in postoperative infection and a prolonged period on a ventilator. Her condition deteriorated. She became confused. Her doctors felt the only way to save her life was to do surgery in the next 24 to 48 hours, and the patient, despite impaired cognition, refused the surgery. A psychiatrist was called, and the evaluator at the time, when he saw her, thought she was not able to make decisions, was delirious and lacked capacity. He did note, however, that the patient was on steroids and had not slept for 3 or 4 nights in a row before he saw her. He recommended holding the steroids and adding a sleep agent, and returned the next day. The patient was much better and lucid and not confused, but still refused the surgery, citing several past negative outcomes of surgical procedures. And in light of her resolved delirium, the psychiatrist believed on the second day that she had the capacity to refuse the surgery. So the next slide shows you, all right, so here's the case report discussion. Many patients who are seriously ill will at some point become delirious, which on the surface may cause them to appear without decision-making capacity. The doctor should rely on witness comments made by the patient while they were lucid before proceeding with the surgery. Patients who are operated on against their will are much more prone to complications, including death, because they have no investment in recovery. In cases where the patient and the family wishes are at odds, a chaplain consult can be helpful. And in this patient, even though she fluctuated from day to day, because she was incapable the first day, there were things that were done to make her less confused. Sleep deprivation and being on steroids can increase confusion, so we stopped those, and the next day she was much better. She still said no, but at least the second time, she was lucid enough to be able to say no. So the answer was the same, but her behavior and her orientation were different on the 2 days. So I want to highlight the fact that capacity can fluctuate. It's not a permanent thing. So it's important to reevaluate the patient afterwards and make sure you give the patient the best chance to give their best answer. And they may require a second visit. This patient was able to make decisions even though the decision did not change. Her demeanor and her level of confusion changed as well. So the summary. Though often used interchangeably, capacity and competency are two very different concepts. Capacity refers to a specific decision at a certain point in time. Capacity is determined by a medical caregiver or psychiatric caregiver. Capacity can fluctuate over time. Competency is a legal term defined by a judge. It has all kind of implications that may last a lifetime in terms of other aspects of the patient's care besides their medical condition. And so it's really important to differentiate the two, because you don't want to give someone a competency decision when they in fact are just confused, and that confusion will get better. Thank you. Are there any questions?
Dr. Frierson, thank you for that very, very dense and empathic and informed presentation. Clearly, you've been at this a while, and I so appreciate the differentiation you brought. So, a couple of questions. So, just roughly, what percentage of people do you see at the hospital? So, there's a lot of people who go for competency hearings that aren't in the hospital, but of the folks you see who eventually are declared incompetent, is it a lot? Is it a little? I'm just sort of curious.
It's very rare. We see a lot of patients who are temporarily unable to make decisions for capacity reasons, but as far as incompetency, it's extremely rare.
Okay. So, I took from your talk that any provider who's got some training around capacity assessment can do that. However, I'm thinking there's probably situations where that person would go, oh, this is more complicated, or there'd be some reason that provider would say, I need an expert. I need Dr. Frierson or someone from his team. What would be some of those sort of red flags that you would suggest they are mindful of to say, okay, this is what I need to call you?
I think it's important to look at the patient's behavior. Very often the patient is delirious and agitated, and we need to manage that as well. And sometimes the physician has a personal investment in the patient's decision, so he needs someone more objective to do that. The judge, if he does go to incompetency, the judge will not generally take a non-psychiatrist's opinion, so he may not take that opinion into account. But very often, the doctor needs someone to manage the patient's behavior and their delirium, as well as seeking the competency. That's usually when we get called. It also depends whether you have access to a psychiatrist. A lot of places don't have that access on a day-to-day basis, so the doctor makes the decision as well. But the person who's invested in doing the surgery should not be the person who makes the decision on whether the patient is capable of having the surgery, because they have an investment in that. So it's important to have a non-involved, objective person come in and make that decision. I think the doctor feels better having coverage by having somebody who's seen many patients like this say no or yes, and they feel better about their decision after they get the opinion of the psychiatrist. So again, if we're available, they usually call us, but anybody can make the decision, but the judge is more likely to take the psychiatrist's opinion than he is about a surgeon or another medical caregiver.
So how has COVID complicated the capacity decisions, or, I mean, has it or hasn't? I don't know. This is the world we're living in right now.
I think it's affected everything. We're seeing a lot of patients who are the long-term survivors with COVID, who have neurological findings. We don't know how long they last. It's not like a delirium where the patient might be better the next day. We just don't know at this point how long that can last. We've seen patients who were demented, who had COVID neurological findings that lasted for months. So again, we can't say for sure how long that will last, and very often the decisions are made. And the other problem with COVID is that because of the worry about infection, very often when someone is dying, they can't have the loved one they want there with them, because they're at risk as well. So dying alone makes them much more depressed and more anxious. A lot of patients who have drug abuse issues, because they can't go to meetings now, they can't meet their sponsor, so their things that were using to stay clean and sober are gone. So we're seeing a lot of patients now who are overdosing, a lot of deaths, people that don't have the usual tools they need to stay clean. So I think it's affected every aspect of medical care, but certainly in terms of demented patients who can't have very often when you have a patient who's demented and agitated, you can avoid medication by having just a spouse come and hold their hand. That can't happen now with a lot of patients because of the visitor restriction as far as COVID. And so it's affected everything that we do as far as psychiatry is affected by COVID. And most of the things are in a negative. We just don't know enough about the conditions in terms of the natural history and the course of it to say this person may be better in weeks or months. We have to go by the moment. And very often the neurological findings and the confusion can last for months. So it does complicate decision making as well.
Thank you. And given your line of work and the stress that providers and really all of the folks working in the hospital system have been facing, I can imagine that you've been called upon to provide care and attention sometimes formally, probably a lot informally, to your own colleagues. So while you're here, I know it's a bit off of the subject that we brought you here for, but you're here, and I'm just curious, how are you doing? How do you see your colleagues doing? What are you finding?
I think a lot of physicians, because everybody is very determined to give the best quality care. A lot of psychiatrists at other places will go in and use an iPad or not go see the patient. But I made the decision early on that I'd be at bedside. And I think that's really important that the doctors know that I'm going to be there in the same way I've been before and help them. Most of the conversations with doctors are in the hallway, and we talk about what is it like to care for these patients. They debrief a little bit. I think it's important that they have a chance to do that. We also wrote an article about a year ago about doctors and the stress they were under with COVID, and asked them to make their suggestions about what they think has helped, and that article will be available to you. I'll give that to the moderators, so you'll have that with you. But I think, generally speaking, doctors will talk to you in the hallway more than they will talk to you in a specific. It's more informal, because very often everybody wants to believe that they're handling things pretty well. Doctors are notorious for not taking care of themselves, and so having a chance to debrief. I had one doctor say to me, "I'm glad you asked me that question. Nobody else has." So things like signs that say, "Thank you for all you've done for us," "Our heroes work here," those kind of things that we take for granted really mean a lot to doctors and nurses, especially nurses. Because when I see a patient, I will see them for like 15 or 20 minutes. The nurse is there for 10 hours. Sometimes we underestimate what it's like to care for patients for that period of time. So I always say to the nurse, what do you think about the patient? What do you think about their mental status? What do you think about their decision-making capacity? Because they're the ones that are there at the bedside. And so giving people a chance to talk about what this journey with COVID has meant to them really impacts patient care in a positive way, because it leads to less frustration and less burnout, and that helps us all.
Thank you so very much. So appreciate your time and expertise, and most importantly, your care. Thank you very much.
Thank you for asking me.
Thank you all for joining us today for the 2022 Medical Ethics Symposium. I'm Dr. Hasselbacher. I'm a pulmonary critical care physician with Norton Pulmonary Specialists. I work out at Norton Brownsboro Hospital, where I'm the ICU and respiratory care director. I'm going to be talking about non-beneficial treatment. Particularly, the focus is going to be on trying to facilitate conversations with patients and surrogates who are requesting these non-beneficial therapies. So before we really get into that, we have to know what we're dealing with. And this was a review paper that was published a couple years ago, where they went through and really tried to determine the scope of the problem. So I have this here for your reference. But looking at it, first we have to define it. And this has been a hard problem, and even in this study, they had difficulty sort of figuring out the extent of the problem, because a lot of studies use different definitions. And particularly some of the terms looking at these papers, things like futile, inappropriate, disproportionate, make sort of hard to compare apples to oranges. So they did the best they can. But one of the things that's come out of this is clearly non-beneficial treatment is a much better term. And that's something in modern ethics that we're trying to push to sort of change the language of how we speak about that. And they define that, and it's defined as an intervention that's ineffective in achieving the desired goals of the patient. Another way of saying it, and these again are just repeating sort of trying to get our head around what the scope of this issue is. Interventions that are a disservice to patients who are subjecting to ongoing and likely uncomfortable conditions without benefit. A treatment that is likely not going to help in terms of not providing a definitive improvement in their therapy just because the patient had an incredibly poor prognosis, regardless of what was going to happen. This last term is really what this paper sort of came to the head with, and it's obviously a very technical term that I'm not going to read for you. You can read it yourself. But frankly, it means we tend to do a lot of stuff to people at the end of the life that doesn't change the outcome. And we need to be sensitive to that. So now that we sort of have a handle on what the problem is, how prevalent is it? How frequency? And I'm not going to read through all of these, but there's an awful lot of stuff that we're doing at the end of life. And if you look here, in these papers, anywhere from 33 to 38% of patients near the end of life receive some form of these non-beneficial treatments, whether it was resuscitation. These patients, a lot of them, 42% died in the ICU, 44% died in the hospital. There's not a law that says we have to die in the hospital. But unfortunately, that's the default setting of our healthcare system. And if that's not what people want, it's important to make plans for that in advance. Other things, dialysis, radiation therapy, antibiotics, just lots of things were done. And you can see in various percentages depending on what studies they were looking at. The last couple too, in terms of, chemotherapy and ICU admissions, a third of patients received chemotherapy within the last 6 weeks of life. And given the nature of how chemotherapy works, that's not likely to impact their outcome there. So now that we've identified sort of what it is, and then we've talked about how prevalent it is, what do we do about it? And this was a really interesting paper that came out last year talking about sort of a mechanism to get around this problem. And what they did is an academic medical center, they trained their house staff and doctors how to sit down and talk to families. And they created this sort of very structured approach with certain goals of conversation, looking at time-limited trials, where they sat down with the families and had very structured conversations about what they wanted, what were the outcomes of care, what were their expectations, and to get a better handle on where the patient and family were with their, goals, with, what was technically feasible based on their presentation. And they studied both before they, did this teaching and then after. And looking at the results was just very interesting. What you can see here, first and foremost, the number of formal family meetings went from 60% to 95%. So, and I think what's interesting with a lot of these statistics is frankly what was happening beforehand. Because if you look at these percentages, frankly, and I do think that these numbers are probably representative of, healthcare in the United States on whole, only 60% of, families were having formal meetings throughout their ICU stay. And so when they switched to this structured, fashion, the median day of the first meeting went from day 5.5 to day 1, which I find just shocking, that you'll have someone in the ICU for 5.5 days and you haven't talked to the family in a formal manner since then. And so clearly this structured approach did a great job of enhancing that communication with the treatment team, getting that face-to-face family providers on day 1. And what's interesting, that if we look what they talk about, talking about the risk and benefits of ICU treatments went from about 35% to almost 95%. We can't do anything in healthcare without informed consent. We're supposed to sit down, whether when we get admitted, when we're having surgery, doing any intervention, where we have a thoughtful discussion about the risks and benefits and pros and cons of any intervention. It's informed consent, it's required. But here, in only 35% of cases, we weren't having that conversation about the risks and benefit of ICU. An ICU admission in of itself is a procedure that, has a lot of things tied into it. And clearly, we're not doing a great job talking about that informed consent for the process prior, but clearly after the intervention had a significant improvement. Talking about what was important to the patient, 46% up to 98%. Looking at clinical markers of improvement. And I think this is very telling. When we talk about the hospitalization these days, there is a flurry of numbers and interventions, and particularly with connected families, with getting feedback on lab results. It's really easy for families to get honed in on one number or one factor. And the question is, of all the cornucopia of lab values, oxygen levels, vitals, everything, what's truly the thing that we care about? Because yes, their oxygen levels may be getting better, but their kidney function's getting worse. What's the factors that we're following and are caring about? And making sure that the family is on board to say, what are we looking to improve? What's the metric that we're wanting to follow to say that we're going from point A to point B and getting where we want to get? With these interventions, they had shorter ICU stays. And obviously with, our current healthcare finances, shortening the ICU stay definitely saves everybody money. But what's interesting is even though they shortened ICU stays, the mortality was the same. So, they were, and if you look, less invasive with the ICU procedures, 85 versus 72. So we were doing less stuff. People were in the ICU shorter periods of time, but the mortality didn't go up. So clearly, this process was identifying individuals who didn't need extra interventions and were successfully not, intervened on with whatever it was, central lines, dialysis, who knows. But regardless, the unnecessary escalations of care that maybe weren't going to be beneficial to that patient were with, not pursued, but more people didn't die as a result. So clearly having these conversations got appropriate care to appropriate patients. It wasn't that anything inappropriately was being held. So I think they did a really good job with these conversations, getting people what they needed. The one thing I found really surprising with this study, though, is family satisfaction really didn't change, which is a little mind-boggling that you've had this interaction with the families and getting, in with them day one and having those conversations, that there wouldn't be a satisfaction bump. And for whatever reason in this study, there wasn't. But regardless, the overall, goals, reducing length of stay, reducing, potentially non-beneficial therapies, and getting everyone on the same page on an earlier stage of the hospital course clearly was beneficial. So these last couple slides, I just want to talk about sort of my clinical experience, as an ICU physician, and having these conversations with families to hopefully allow you to learn from these studies, but also from my experience in handling some of these interactions. One of the first things is obviously we have an obligation to provide treatment options. Whenever we sit down with a family and we have a course of action that we need to discuss, whether it's treating a pneumonia, treating a cancer, there's always an option, one choice or another. Now, some may be riskier and less benefit, and others may be low risk, more benefit. Regardless of what it is, it's important for us as clinicians to have those conversations with the patient and their families. What's very important, though, is they're offering medically appropriate options. Because one of the things is that as a clinician who's been educated in medicine, we're often talking to people who don't know medicine. They have no knowledge of healthcare and they're dependent on us. So if we offer an intervention to them, implicit with that offer is the suggestion that it would be of benefit to them. Because as a clinician, if I'm offering an intervention to someone, why would I be suggesting, hey, let's do this, if it wasn't going to help them? Because we usually don't do things that aren't going to benefit people. So if there's a treatment, in medicine, just because we can do it doesn't mean it's necessary or appropriate. For example, we don't use antibiotics in heart failure. We don't use antibiotics for viral pneumonias. We use appropriate interventions for the appropriate disease. And we want to make sure we're conveying that when we have those conversations. Big example of this, particularly with sort of end-of-life goals. A family will say, hey, don't intubate me, but when my heart stops, I want you to do everything. And that just doesn't make sense. If someone has a bad pneumonia that's getting worse, and it gets to the point that they can't breathe, and they don't want us to put them on the ventilator, intubate them, but then when their heart stops, oh yeah, bring the cavalry now and malfix me. Whereas if we had gone on the ventilator, we could have potentially prevented that. That obviously doesn't make rational sense. That's not a medically appropriate decision. So it's important when families sort of bring up things like that are conflicting with appropriate medical care, that we sit down with them and talk to them about why that's not a medically appropriate decision, and here's why. And some people may then say, oh, I hadn't thought about that. Yes, in that case, I do want to go on the ventilator. I don't want to go on forever, but maybe just a short period of time to see if I'm going to get better. Well, then you've engaged with that patient. You've determined what their goals of care are, and you can get a treatment course that works together. The other thing, it's very important to prepare families and patients for the likely outcomes. With clinical experience, we often will know when someone rolls in, ooh, their kidneys are going to fail in 2 days, or ooh, their breathing may get worse and we may have to put them on the ventilator. If we tell the family and the patient that on day one when we see them, one, if it happens, they're prepared. It's not a shocked, oh my gosh, dad's going down the tubes, what's going on? We've prepared them for that. And so they're not shocked, and it's not a panic reactive, hospital course. The other thing is it gives us credibility. Oh, that provider told us this was going to happen. We were ready for it. We're not panicked. We understand, and we've made a plan for that. So you want to definitely practice proactive medicine when possible and prepare those families for those possible things. And if they don't happen, that's okay. But at least you prepared for the worst case scenario. The other thing that's important when talking about families is, and it has to do with language and phrasing, it is very important when we're talking to people, I've found, to empower them to make a positive decision. If you're asking someone if they want something or not, again, and this goes back to the implicit, if we're offering an intervention, there's implication that it's of benefit. So if you're asking a family member or patient to say, no, I don't want that intervention that may be benefiting me because you're offering it, that's a really hard thing to say no to. So particularly with regards to, say, for how I handle my end-of-life conversations. I might say that, hey, we're doing everything we medically can to try and reverse this process. But if despite everything that we can do, things get worse, and you're having trouble breathing or your heart stops, at that point we can take measures to maximize your comfort and allow you to die a natural death. Are you okay with that? And that allows, approaching it in that fashion, allows people to say, yes, I'm okay with that. As opposed to saying, no, I don't want to go on the ventilator. I don't want to be resuscitated. And just that subtle change in how we phrase it just makes it easier for an individual to make a choice for themselves. The other thing, and this is unfortunately some old school thinking that I think has still carried through, DNR isn't don't treat. We continue to treat. We do absolutely everything we can. It's just allowing a natural death when the disease is refractory to medical therapy. We continue to treat. Our goals of care may change. We may make a shift from treating a disease we can't treat to symptoms we can, and maximize quality of life there at the end. So additionally, just to recognize, we're definitely stewards of healthcare resources, not only for the patient in front of us, but also for the community at large. And I think we need to recognize that healthcare is not unlimited. Particularly now with COVID, there's a massive blood shortage, and I'm sure a lot of people are aware of that. And blood, and I use this just as a specific example, is a very scarce resource. People are sacrificing, their time and literally part of them for the betterment of other people. And as healthcare providers, I think we have to be very careful and good stewards of that generous gift that those individuals are giving in terms of blood, platelets, and other products to help each other. So I think it's very important that we just don't knee-jerk transfuse just to make a number better. We need to ask ourselves, why are we using this blood? Is it truly going to benefit or improve the patient's condition? We really also want to make sure we're having an appropriate conversation. We don't want to be giving blood at 5 a.m. just because the labs came back then, when we were going to have a conversation in the morning about maybe transitioning to comfort care. I think that would not be an optimal use of blood product, and it's something that we just need to be conscious of, particularly because we're stewards for the community as well. The other thing I want to mention is hospice. Obviously, this is underutilized. It's a multidisciplinary team of providers with the goal to maximize quality of life, not only for the patient, but for the families as well, too. And hospice, in addition to providing supportive services for the patient, also for the family in terms of counseling and support for long after the patient has passed on. Just a personal anecdote, one of my end-stage COPD patients, we'd gotten enrolled early while he was still able to somewhat get around. Hospice got him out to the lake fishing. That would not have been possible without that umbrella of support around that individual. And those are opportunities that are able to be taken advantage of when we're utilizing hospice early at the end of life as opposed to the last few days. So finally, I want to talk just about Norton and how we're doing non-beneficial treatment. There is a new policy process in progress that's going to allow us as an institution to sort of deal with these non-beneficial treatment requests in a very structured and formal fashion to help support our providers and staff. First of all, there's no obligation for a provider to provide treatment that a physician believes is not appropriate. And this is taken from a draft of the upcoming policy, but it's any medical procedure, treatment, or intervention which the patient's attending physician reasonably believes is not medically appropriate. Because in the attending physician's best medical judgment, such treatment cannot be reasonably expected to yield the intended clinical benefit or achieve agreed on goals of care. Now, we can't abandon the patient. You know, if a family comes to you and says, hey, we want to do whatever, it may not be appropriate, it may not be indicated, but you can't just say, I'm not doing that and walk away. It's still your responsibility ethically to take care of that patient. You don't have to necessarily do that intervention that they've asked you, but that would be a point to engage with the conversation, call for friends and backup, and potentially activate, you know, this formal policy and protocol. First and foremost, if the patient family finds a provider who does think that's appropriate and willing, by all means, transfer care. But a formal process with ethics consultation and independent physician evaluation, which then engages the family to come to some definitive agreement in terms of how we're moving forward when faced with a question about non-beneficial treatment. So to that end, thank you for your time and attention. I want to end with obviously this quote from Hippocrates. I will prescribe regimens for the good of my patients according to my ability and my judgment and never do harm to anyone. Thank you for your attention and time.
Dr. Hausbacher, thank you so much for covering so much territory. I mean, it's you and I both know, and I think our audience certainly knows how deceptively complex all this is. And undoubtedly, COVID has made it more complex. And I was wondering if you could help our audience, help us sort of appreciate some of the challenges that you face, because you're in the ICU, you're a pulmonologist. And are you a pulmonologist? Okay.
Yes.
Can you fix that? Yeah. I was thinking heart, but then I
Pulmonary
lungs.
critical care.
Yeah.
Oh, yes.
Yeah, pulmonary. Yeah. So you're a pulmonologist. COVID that's right there at the operating system with COVID. So what are some of the challenges around non-beneficial treatment, and more particularly, how have you found yourself addressing those?
Yeah, and obviously that is something that is plagued our country, unfortunately. I think that the amount of misinformation that has been spewed across the internet, over the last year and a half, unfortunately has done real damage to us and cost people their lives. Misinformation about vaccines and vaccine safety, alternative treatments that are clearly not effective. But when we have these loud voices in little pockets of the internet that are reinforcing themselves, and it's impacting people's medical decision-making, where they're choosing alternative treatments that, frankly, and when I say alternative, they're not really alternatives. I mean, because now that I've said that word, alternative suggests it's an appropriate option, and frankly, they're not. I mean, they're using medicines that are of zero benefit against the disease, and frankly, have toxicities in and of themselves. So using non-approved interventions, whether it's drugs, whether it's choosing not to get vaccinated, and particularly the vaccination and that misinformation has allowed the virus to churn through our community, which then in turn is causing increased breakthrough infections in our vaccinated and in our most vulnerable individuals, almost certainly some additional deaths. So it's this misinformation on the internet literally is doing harm to us as a society. And yes, on a almost weekly basis, having to talk to someone about what they're finding on the internet and why it's not appropriate is become an intricate part of our daily rounding and care.
Thank you. Another question that comes up is you laid out a process to engage patients and or their families, particularly when things seem to be heading in a direction that may end up with the patients dying. You do everything right. You say it early. You say their kidneys may fail in 2 days, and they do. And you're spot on with everything. Yet the family's emotional states becomes more and more hostile towards you. And you're doing the right thing. The bedside, everybody's doing the right thing. But so when faced with hostility, that's a tough place to be. And I was wondering if you had some pointers for us on just how you've dealt with that and some ideas you might have for saying, because you've been out there on the battlefield, the COVID battlefield, for a couple of years now. And what are some things that you've learned that could help
Yeah,
us?
and that's clearly even before COVID, dealing with families who are struggling with a critically ill loved one. And then at the same time, you're asking to help make decisions that may impact their outcome. And that definitely is sometimes a bumpy road. One of the things I always remind patients and families is I'm not asking what the family member wants. If I had a magic wand, I'd be asking the individual in the bed, and ask them to tell me what they would want. And just reinforce with the family that way there shouldn't be any guilt. It's not a decision they're making. They're just telling me what the individual, the patient would want. The other thing I've run into is sometimes, particularly when we're starting to bump heads, in terms of, and there is that sort of hostility that is maybe starting to brew, frankly, hopefully reading the room and recognizing, and at that point, I don't push the issue. We're still continuing aggressive care. We're continuing to do everything we can, present the facts in a factual manner, and not uncommonly, with just time and not nudging them every single day, but just letting things sink in with that objective data presentation, slowly, little by little. Oftentimes, family will ultimately see the writing on the wall and then approach the team, in terms of, hey, wait a minute, let's transition our goals of care or do something a little bit differently. And so I think engaging the family in conversation is very important. Definitely want to be proactive and do it up front, but recognize sometimes it's important to step away for a second, still intervene and talk with them every single day, and update on what's going on in a factual manner. And oftentimes with that pause, allowing families to see we're actually doing things and seeing the patient either get better or not get better, helps it sink in and then allows a re-engagement in conversation.
Thanks for that answer. And I love that you brought the magic wand into the equation here. So if there were such thing as a magic wand, and if you had the magic wand, and if you could use that in the ICU to help people to have a good death, what would you hope for? How would you use that?
So I have to be careful answering that because obviously I know what I would want personally, but I can't speak to what an individual would want. But what is important, I think, is to have informed discussions early, just to let people know their options. Fortunately or unfortunately, the default setting of our healthcare system is if your heart stops, you get CPR. But frankly, we know as an intervention, even if you have an out-of-hospital cardiac arrest and it's from a heart condition, 90% of those people don't do well. But yet when we have people who are dying in the ICU, we apply that same intervention that doesn't work really well for people for what it was designed to, and we're applying it to everyone across the board. And the thing is, it doesn't necessarily have to be that way. And I think really from my outpatient experience with my end-stage COPD patients is having that conversation with them early, that and providing them options. You know, if they want to be at home, by all means, we can set that up and make it happen. If they want to have family, just where do they want to be at the end of their life? What do they want to be doing? And that's often where early engagement with hospice, providing that umbrella of support. Because if you don't have those proactive early conversations, when it's someone's time, if their only outlet is to pick up the phone and call 911, that's their only way out. And there are more options, but we have to have those discussions. And obviously, if that's what someone wants, so be it. But I think it's a missed opportunity to at least allow someone to explore the options of what they want for themselves with conversation early in the disease state. Because I would much rather have a conversation with one of my patients at 2 o'clock in the afternoon in the office, when everyone's there and we can just talk about things, as opposed to having to have a panicked 2 a.m. phone call with that patient's son, daughter, and say, what would mom want? Because that's not a very good conversation. And so, you know, as far as a good death, it's what an individual wants for themselves. And I think it's our job as providers to make sure that they have the time and the resources to think about it in advance, whether it's with EMS DNR forms, most forms, you know, to get a clear picture of what that individual would want for themselves. Because I would much rather talk with someone than their loved one.
Thanks. Your presentation, your responses, well, they bring out the chaplain in me. And, you know, we've known each other, and it's been a hard slog. And, you know, what you're just talking about are some of the most intimate conversations that two human beings can have with each other. And I certainly appreciate that you've built up over time a certain emotional muscle group to sort of help deal with all that. But this is hard. It's hard. And when you get pounded on by families because they want this or that and whatever, it's hard. And, you know, how you doing? Just how you doing?
You know, it as a healthcare provider, you know, we are all probably approaching breaking points. I mean, this has been going through a pandemic like this has been soul crushing, and everyone is spread to their absolute limit. You know, our nursing staff, we just don't have the staff where everyone's working harder than they want to, but we're doing it because we have to. It was definitely sort of going through this process. You know, early on, everyone was afraid. You know, I don't want to bring it home. I don't want to get my kids sick. I don't want to get my wife sick. I don't want to get it because, you know, I don't want to die. And that fear, and then the jubilation when we had a phenomenal vaccine early on. It's like, there's going to be an end to this, that we're going to get through this. It's going to be another couple months. We're going to get everybody vaccinated and get through. And so there was this little sense of hope that then got dashed. I think because so many people chose not to get vaccinated, making a personal choice instead of a public health choice for the community, and then Delta hit. And because we had this huge percentage of individuals weren't vaccinated, and it just is absolutely heartbreaking to have a young person after another young person die from what should have been a preventable illness, fueled by almost certainly misinformation on the internet and political rhetoric. And it just was painful. You know, obviously kids have now been able to be vaccinated. When my kids were old enough and got their vaccine, fantastic. I finally felt a little more protection internally. But even now with this last wave, we're tired. And I think everyone's just hoping that this is going to be that last hurdle, and it's not going to go away likely, but that it's going to percolate through time in a more manageable way, that we can sort of reinforce our staffing and get some sort of normalcy back again.
Thank you so much. And I know for myself personally, and I'm sure there's many, many people feel better knowing that you're out there doing what you're doing. So thank you very much.
Thank you.
Appreciate it.
Well, I want to thank my colleagues in the 3 previous presentations. I hope you've got a sense of some ways that their talks can be of help to you, and I certainly hope that what we'll be talking about next will also be of help to you. Dr. Hasselbacher finished up talking about non-beneficial treatment, and that is, quite frankly, often the times when we find ourselves bumping into families and them wondering about what I want more, or I don't want that, I want this, and those are often the moments of ethical concern or ethical question, right? So what I'm going to do in this last presentation is walk you through the model at Norton Healthcare that we've been developing for a number of years for ethical consultation. So it's our integrated ethics program, and it's the consultation process. So this is a really big old slide with a lot of moving parts, and it just shows all sorts of things. I'm going to break this down, but I needed for you to have the gestalt, the larger picture of what we were talking about. I'm going to run through these with this just very quickly as categories, and then I'm going to break these down so that you know what's going on. It starts up here in the corner when there's a request from for an ethics consult. Then it moves through these green boxes, typically with our chaplains, about how this is handled. And then decisions are made as to who it goes to, and then once it goes over here to the ethics committee, the consultants, there's a process. We use the case method right here, and it walks through those 4 steps. Actually, it's cases, but for the purpose of this, we don't put the S on there. And all the way through with the purple, there are some experts that are available to help. So that's the gestalt, that's the big picture. Now I'm going to simplify this down to something very, very short and sweet, and it is this. Do you need an ethics consult? Call the Norton Hospital operator. All that stuff I just showed you, that's what's going on under the hood. That's stuff that you don't necessarily need to see or you don't have to have much expertise with. You just need to know that it's going on, and I'm going to unpack that with you. But the takeaway from this is, if you're thinking, my gosh, I've got an unbefriended patient situation here. What do I do? Call for an ethics consult. If you're struggling with competency and capacity and you're not sure, are those even the right categories? I need someone to help me with that. Call for an ethics consult. Certainly, if you're in a situation where you're facing questions about non-beneficial treatment requests, if a patient is demanding certain things and feels conflicted or having conflicts with their families, they can call for an ethics consult. Now, what's important to know is that ethics consults are just that. They're consults. The consultants, be it a committee or an individual, they don't come in and make pronouncements over this is what you should do ethically. If there's a legal issue, yes, that will be brought forward. But for an ethics consult, they're going to weigh through the situation and say, this is a recommendation, or this course are both ethically are both courses that have ethical support for doing that, okay? But the take-home message for all we're going to be talking about, I'm going to come back to this at the end is, need an ethics consult? Call Norton Hospital operator, and they know how to get that process going. Okay, so I'm going to break down this diagram by color. All of this green, I'm not going to walk you through every one of those, but it's just important for you to know that there is some sophistication going on and is in place to ensure that ethics consults, when they're requested, they happen in a timely way, and second, that you're helped. That's the bottom line, that if you call us, you're going to get help in a timely way, and then second, and it is in fact going to be helpful. So most typically, the calls come from the operator to the hospital chaplain. And we have, are you a PRN chaplain? They fill out worksheets, and it just sort of directs them through all of these boxes. And one of the differentiators down here towards the bottom is the timing. If it's Monday through Friday, 7 a.m. to 3 p.m., we're going to send it to the ethics consult person at the hospital or in the medical group
But if it's outside of those, we have a different route to get somebody moving in your direction. And then down here, if it is, there's my mouse, if it's not urgent, okay, if it is not urgent, then we're going to wait till the next day, next business day. But if it is urgent, which very often these are, then we also have a way to accelerate this and get somebody to be helpful. Sometimes these things, a consult can wait a couple of days. I mean, you kind of see something brewing and we don't want to wake somebody up in the middle of the night. But you know what? If we need to wake somebody up in the middle of the night, we're able to do that, and we have the folks on hand to do it, okay? So you place a call, all of this begins to happen. And at the end of this, what's going to happen is you see a little more green in there, there's going to be an ethical question formed. Given that the patient wants this, but the providers believe that, is it ethically appropriate to do this? That's a way to state an ethical question. There are other ways, but just as an example, that is going to be referred to typically the ethics committee contact person. These, you don't need to know who they are. It's not a secret, but I mean, we have ways of contacting them. We have cell phone numbers and pager numbers, and we can reach them, and we're going to get them. And they're going to receive that ethics question. And so what we're trying to do by doing that is speed up the process by getting them moving as quickly as possible, or I should say as quickly as necessary to be helpful in the clinical situation. Now, if it's late, like in the middle of the night, on the weekend, it's urgent, we have an on-call ethics consultant that we can call right then and there, and they can begin that process, okay? And once it's handed off to the point of contact for a committee, then they activate the committee process. And this is the committee process here. And right up here in the top, you see the yellow box. And what we like to say is no one consults alone. So particularly at the committee level, we like to have as many people as possible working together on that request. And so sometimes that is a couple of people. For more complex cases, it could be the entire committee, or folks could be brought in from RISC or from Dr. Hasselbacher mentioned the blood bank, or whoever is needed to do that. And we conduct the consult according to this model called the CASE, or as I mentioned a while ago, the CASES model. And this is how that breaks down. It's a 4-step process. First thing to do is to clarify the consultation request. What's being asked for here? And that's that ethics question that I was mentioning a minute ago. And all the way through this, you see there are ways for the committee, if the case is outside their area of expertise, or just to say generally, if they just feel like they're getting stuck, there are ways for the committee to request help from our expert ethics consultants to join their process, join the committee's process to help them with this. So clarifying the ethics concern. What are we being asked to do? It's like anything. You can't do anything till you really understand what the question is. What is being asked of me? So once you have that, then the A stands for assemble the relevant information. So what's going on clinically? What is happening at the bedside? What are the various people saying? But assembling the information also means somebody else out there in the universe has had this problem before. So it's research, and there's all kinds of ethics databases that our folks have access to say, okay, somebody else has had this problem, that faced this issue before. What did they do? What can we learn from them? I was recently made aware of a case, not at Norton Healthcare. I actually teach an ethics course here at one of our universities. And the student brought forward this case of a patient who presented the ED in about to go into cardiac arrest and had tattooed across his chest, no DNR. What do you do with that? What does that mean? And so amazingly, they went on and they found another case somewhere where somebody had dealt with that and written it up. Now, it was a little bit different, but it just helped accelerate their thinking. That's part of what assemble relevant information. So clinically, through research, that's what it is. But once you have all of this data spread on the table, all this information, now you got to start putting it together. What's relevant to the situation? What is irrelevant to the situation? What information that we've learned from other cases is relevant to us? And it's sorting that, it's synthesizing, sorting it out, and then coming to our best thinking of the best minds in the room to figure out what kind of recommendation can we make. Okay? And that is really the tough part, because sometimes it's difficult to reach consensus. And again, if the committee or the consultants aren't finding themselves being able to reach a consensus, we have experts who are more than happy to come in and be a part of that process. Then the last thing is to explain the synthesis or explain the recommendation. So it's going back to the providers, going back to the person who made the request. Maybe that's the patient, maybe it's the family, and saying, this is what we've done. This is the thinking that we have come to, and this is an ethically appropriate course that we recommend you considering. Again, not saying this is what you have to do, it's a consultation, and so providing that consultation. So, clarifying, assembling, synthesizing, explaining. Now, here at Norton, we've been using this process. If you're not a part of Norton, you might be thinking, that's all very fine and well. Where do I get that? Well, there's a book. It's called The Ethics Consultation, Responding to Ethics Questions in Healthcare, and it's free because it's from the VA. You can go out, you can do a search for it, and this is the second edition is the most recent edition. But the VA has literally got dozens of pages of ethics resources, and we like their resources because it's simple, easy to use, it's free, and we have found it to be beneficial. Okay. Then the last thing we're going to do is we're going to document the consultation in Epic and the agreed upon recommendations, and there's a whole process for doing that as well. Okay. So I'm going to go back to where I kind of started this particular presentation, and that is, if you need an ethics consult, what do you do? Now, if we were in a room together, I would hope all of you would say together, you call the operator and ask for an ethics consult. And they'll push all their buttons, and a person will be back to you in an appropriate amount of time. Well, that's the overview of the ethics process, and I hope it feels easy. I hope it feels practical. I hope it feels welcoming, and I hope it feels like it's something you will use. We are in the process of expanding our capacity for our ethics consultation service, and among a variety of things, it's bringing forth a more robust consultation process, a more timely consultation process, and we're also in partnership with the University of Louisville to hire an ethicist, partly funded by Norton Healthcare, the Peter Store Fund, and partly funded by the University of Louisville to do teaching in their ethics program through the Department of Philosophy. So we're going to have an ethicist this summer who will be able to add additional expertise to the growing expertise that we have throughout our system. So we're very, very excited about that development. If you have any questions about our ethics program, about our ethics consultation service, about what we have, if you have a question about an ethics, I just want to sound something out, don't hesitate to reach out to our chaplains in particular. If it'd be helpful to call me, particularly about anything administrative, please reach out. I'm more than happy to talk to you. Our number one goal is to be helpful, and to be helpful in a timely way. So whatever we need to do to meet those goals is what we'll be able to do.
I'd like to thank our speakers for their preparation and flexibility for this program, especially under these difficult weather conditions. Most importantly, I would like to thank all of our staff and providers who throughout each and every day do their very best to ensure that our patients receive great care at Norton Healthcare. A couple final reminders. Remember the email address, ethicsquestions@nortonhealthcare.org. Always remember that ethics consults can be an important and effective way to ensure better care for our patients, families, and staff. You will be receiving a link for a program evaluation. We hope that you'll take a few moments to complete that and return it at your convenience. And last, thank you for joining us this evening. As we always say, stay safe, keep the faith. Good night.